Thank you, Dr. Yasin, for the introduction. Are you able to see my slides now?
Yes.
Okay. Bismillah ar-Rahman ar-Rahim. Thank you all for coming to the meeting today. I will provide today an update regarding attainment trial. To start, nothing to disclose other than a co-principal investigator for this trial, and I'll be presenting on behalf of the principal investigator, Dr. Mohammed Bawazir, and my team listed here in the slides. This trial is an investigator initiated and no financial support to disclose. For the sake of time, we're gonna get started with a quick overview of ketamine and discuss an update of attainment trial. Ketamine is a phencyclidine analog synthesized in 1960 as an anesthetic agent that has less psychotropic effects than PCP. It's available in the US and Saudi Arabia as a controlled substance and acts as a dissociative anesthetic and analgesic agent. It produces type of sedation at cataleptic states where the patient eye can remain open but sensory depressed, initially used for pre-hospital analgesia in combat causality. Ketamine has a variety of pharmacological effects at different receptors. Fairly complex pharmacology make it interesting. It has sympathomimetic effects, and it acts as a catecholamine reuptake inhibitors, and it also had a negative inotropic effect. It also has a bronchodilator property due to its anticholinergic effects, and it tends to preserve respiratory function and doesn't cause respiratory depression, especially with sub-anesthetic dose, and it has also a psychomimetic effects as a side effect. And some studies showed slow infusions or produce lower rates of the side effects compared to the IV push or when given in a combination with a propofol as a ketofol. Recently, there has been data for using ketamine at a critical care settings, and summarized here in this slide. For the acute pain management analgesia, it has been used as a part of ERAS protocol as a multimodal opioid-free analgesic, and most studies in operative setting and emergency department for procedural sedation as IV boluses, infusion, IM, and intranasally, which might be helpful for patients with a limited IV access. In PADIS guidelines, ketamine also recommended to reduce opioid consumption in post-surgical patients. It's also studied as sub-anesthetic dose to control acute pain in traumatic rib fractures who are severely injured resulted in reduction of pain score and morphine requirement. In general, based on our literature review, ketamine could potentially benefit those who require painful procedures and in those having opioid tolerance, high risk of respiratory depression, and high risk of opioid abuse. We're not gonna discuss too much for its use in another indication. However, it can be used in asthma, as ketamine acts in MDA antagonist, producing anti-inflammatory bronchodilatory effects and smooth muscle relaxation, and have been used in patients refractory to other treatment. It's shown to increase lung compliance and reduce oxygen requirement. However, larger anesthetic doses are required for those patients, which put them to a potential increased side effect as psychomimetic effects. Ketamine occasionally used in patients with a status of epilepticus, particularly in refractory and super-refractory seizures, and has been shown to have a neuroprotective effect and anti-inflammatory effects. However, we don't have a good treatment protocol for how to use it, and the practice varies across the institution. And a recent meta-analysis that included a case series and case reports reported an efficacy of 70% for that indication. For alcohol withdrawal, ketamine resulted in reduction of diazepam in retrospective studies, especially those with a benzodiazepine resistance, and had a potential use in patients with delirium tremens. For RSI, ketamine quickly replacing etomidate in induction sedations in RSI at several institutions, and its property for a quick onset and offset with no adrenal insufficiency risk that potentially seen with etomidate. I'm going to spend most of the time now for ketamine in the ketamine indication as analgesic sedation. There is a lot of interest for using ketamine as an analgesic sedative in ICU. Traditionally, opioids fulfilled this role, but as I mentioned earlier, ketamine can be used as well. When compared with other sedatives in ICU, it has a fastest onset within 30 to 40 seconds and short duration within 15 minutes. Most importantly, majority of sedative agents can cause hypertension and bradycardia, while ketamine tends to cause hypertension and tachycardia. And we provided an overview previously and summarized at our mini review articles published in Saudi Critical Care Journal. Also, in our mini review, we highlighted the several retrospective observation studies trying to assess ketamine effect on improving sedation and pain score range. There is one trial that kind of highlighted the potential harm in heart failure patients and found a decrease in cardiac index, increase in pulmonary capillary wedge pressure, and increase in systemic vascular resistance due to myocardial depressive effect. So majority of those studies are retrospective observation studies with a small sample size and at surgical ICU settings, or randomized controlled trials that focus on comparing ketamine to placebo or to study drugs, like ketamine with morphine. However, most of the patients in ICU are sedated with a combination of drugs. Also, most of the trial has a limited focus on patient-centered outcome, like a duration of mechanical ventilation or ICU length of stay as a primary outcome. And they are favoring surrogate outcomes such as sedation score and change in analgesic and sedative requirements. So no robust clinical data and comprehensive assessments of adverse events associated with ketamine in mechanically ventilated patients, leaving a significant knowledge gap, which have been reflected in a wide variation of use of this agent as a sedative agent in ICU. And that leads us to our trial, attainment trial, and a study protocol is summarized here and also published at a trial journal for more information. In brief, we aim to assess the effect and safety of adjunct low-dose continuous infusion ketamine as analgesic sedative agents compared to standard of care, and it's conducted in a single center. It's a randomized controlled trial and planned to enroll 80 patients, and it's registered at clinicaltrial.gov, current controlled trials, and Saudi FDA. Patients are allocated in 1-to-1 ratio after screening for eligibility and obtaining consent to either standard of care, which is a King Khalid sedation protocol that consists of fentanyl, propofol, or midazolam, or the other arm would be adjunct ketamine in addition to the standard of care. Ketamine administration for a maximum of 48 hours and can be discontinued earlier if the patient extubated. Other aspects of care in both groups, including SAP, SPT, mobilizations, will left to the discretion of ICU attending physicians. Study protocol at the trials journal included more information about the intervention stopping rule and the protocol diffusion. The target RAS was left to the ICU attending physician, and titration of sedatives was done by the nurses to target the RAS goal. When patient is deemed to be excessively sedated, the other sedative was held first or decreased, and ketamine was continued until the subject reached the team desired RAS goal. In situation where excessive sedation persisted, then ketamine was discontinued. While when the patient deemed to be agitated, the other sedation rate was increased, or we added a boluses or add Presidex. The decision to continue or discontinue ketamine in this case was left to discretion of treating physician. Our primary outcome is duration of mechanical ventilation, and this outcome was chosen as a patient-centered outcome and based on mechanistic plausibility data that showed ketamine possibly has bronchodilatory effect and maintained respiratory drive and airway reflexes. And because the duration of mechanical ventilation is highly influenced by mortality, we measured also the ventilator-free days to day 28 post-randomization as a co-primary outcome. Secondary outcomes are several and included cumulative dose of pain and sedative medication, the incidence of Residix use post randomization, RAS and pain score goal, hemodynamic status, ICU and hospital length of stay, the rate of tracheostomy, unplanned extubation rate in intubation, incidence of delirium and antipsychotic use, the rates of physical restraints, ICU and hospital length of stay, and mortality rate at 28 days. We also looking at the secondary visibility outcome, including proportion of screened patients, eligible patients enrolled, as well as enrollment rate and protocol compliance. And this figure depicted the schedule of enrollment, intervention, and assessment for each outcome at different time intervals. I'll be talking about the midpoint analysis for a total of 40 patients in the subsequent slides. So a total of 159 mechanically ventilated patients were screened for inclusion and exclusion criteria if they were admitted within 24 hours to medical, surgical, or transplant oncology ICU, and expected to require mechanical ventilation for more than 24 hours. 40 patients met the inclusion criteria and 118 were excluded for the reason listed here in the slide. We do have a very extensive list of exclusion criteria, like patient with a history of dementia or psychiatric disorder, patient expected to have a targeted RAS of -5 or on a continuous infusion neuromuscular blockers, patient on Residix as a primary sedative agent prior to randomization, or patient with a cardiogenic shock and acute decompensated heart failure or myocardial infarction as a prior trial showed harm on those population. We also excluded patients with a liver failure or proven or suspected to have a primary neurological injury, or patient with a tachycardia or hypertension at baseline since ketamine has sympathomimetic effects. We also excluded patients identified as a DNR or those expected to die within 24 hours and patient on ECMO or declined consent. So moving to the baseline characteristic for the midpoint analysis, a median age of 60 patients included, and among those randomized to ketamine, 45% were in medical ICU, 25% in surgical ICU, and 30% in a transplant oncology ICU. A median SOFA is 7 and a median Apache is 17 in ketamine compared to 8 and 20 in the standard of care arm, respectively. The median duration of ICU stay prior to the study enrollment was 10 in standard of care arm compared to 14 hours in ketamine arm. Moving to the duration for mechanical ventilation within 28 days. So about 70% of the patient was extubated within 28 days post randomization to ketamine compared to 50% randomized to standard of care. And the median duration of mechanical ventilation was 4 and 7 in a standard of care arm and ketamine arm, respectively. For the duration of mechanical ventilation at time of ICU discharge and death, about 63% of the patients were liberated from mechanical ventilation post randomization to ketamine compared to 52.6% randomized to standard of care arm. And the median duration of mechanical ventilation is 9 and 8 in the standard of care and ketamine arm, respectively. And this figure depicts the change in secondary outcome, which is the RAS score at 24 hours and 48 hours compared to a baseline with a median and interquartile range. So more patients at goal RAS in 24 and 48 hours in ketamine compared to the standard of care arm. About 60 and 61% compared to 45% and 58% in a standard of care arm. Then moving to the change in fentanyl requirement, 48-hour post-randomization, about 90% of the ketamine patients require fentanyl at a median dose of 69.56, and this quite similar to the standard of care arm, but much higher when compared to a baseline. For the propofol requirements, though less patients require propofol in ketamine arm, around 55% compared to the baseline, the median dose was 14.7 milligram per kg, which a little bit higher than a standard of care arm and as compared to a baseline. For the proportion of patients requiring midazolam were less in 48 hours, were less in ketamine arm, 48-hour post-randomization, yet the median dose is higher in both arms compared to a baseline. Residix requirement noted to be less in ketamine arm, and only 15 patients started Residix at median dose of 6.03 microgram per kg compared to a standard of care. As for the vasopressin requirements, almost similar vasopressin daily doses among the two treatment arms at baseline, and data presented here in a total milligram per day. However, the median norepinephrine and vasopressin daily dose was noted to be very high in ketamine on 48-hour post-randomization when compared to a standard of care and when compared to a baseline requirement as well. For the hemodynamic status, vital signs like a heart rate and that seems to be similar between the two arms, the standard of care and adjunct ketamine arm. Ketamine itself, although as I mentioned earlier, ketamine itself has a sympathomimetic effect and can cause hypertension and tachycardia. However, in subgroup of patients, especially catecholamine depleted patients, it can sometimes cause hemodynamically compromised status. One study looked at a shock index to predict those who will develop a hemocompromised status, and the shock index can be calculated as a pulse rate over the systolic blood pressure, and has been shown in other studies to have a good positive predictive value for predicting the hemodynamic compromise. So in this study, in a previous prospective observation study that included 112 patients of a head injury and separated patient into two arms, low shock index and high shock index, using a cutoff of 0.9. A mean doses of ketamine was used is 1.4, and the diagram as a diagram A in the left side is a low shock index patient, and diagram B is a low shock index, high shock index patient, and systolic blood pressure is low in low shock index patient at the left. Was higher at all time interval. However, systolic blood pressure remained essentially the same, and a high shock index group. So shock index is a good predictor to predict those who will be hemodynamically compromised without just presumed ketamine will preserve hemodynamic parameters and may consider as a step further for our future stat analysis. For the length, for the ICU length of stay and hospital length of stay, a median duration of 12 days in ICU and 16 to 18 days hospital length of stay in both arms was noted in our trial. Other secondary and safety endpoint is presented here for the percentage of the tracheostomy and re-intubation and self-extubation. For the adverse events, in form of delirium, which was reported in 2 patients at ketamine arm, and the data is not presented here in this slide. One patient, we had positive CAM ICU. However, the number of the patients who had the delirium screening performed in our trial was a bit low, shows us where we are in terms of monitoring delirium, and probably we need to do a better job for delirium assessment. No reports for hypersalivation or nystagmus or other side effects. Antipsychotic agent was initiated in 1 patient in ketamine arm compared to 2 in a standard of care arm. The rate of physical restraints, 48-hour post-randomizations, and the mortality rate within 28 days was a little bit higher in a standard of care arm compared to the ketamine. So in general, we had barriers or during the COVID-19 pandemic, the recruitment rate has been slowed down, and many trials have been affected during the COVID pandemic because of the difficulty in continuing under the lockdown conditions. And we have a research staff got infected or even shifted to cover clinically in a highly demanded area. At the same time, the pandemic has been shifted the focus and the reorientation of clinical trials towards COVID-19. And this issue has been highlighted also as well in the recent article published in the Critical Care Medicine, addressing the possible approach guiding the non-pandemic critical care research. So to deal with this situation, we did an amendment in our protocol and was submitted and approved by ethics committee to modify the written informed consent and just accept a verbal consent from the family members with a witness who is not a co-investigator in this trial. We also utilize the video conferencing or Zoom as applicable. Another barriers we have is we need to get the approval of multiple services like the ICU treating physician in addition to the surgery, transplant, and neuro. And finally, this trial is an investigator-initiated trial, and we don't have a financial support, and we don't have a full-time research coordinator. But our research coordinator is a nurses, full-time nurses that are doing a clinical job as well as research continuously. So as for the status currently, an extension of the trial has been granted by our institution research affair for 1 additional year. As of today, a total of 66 patients has been enrolled, and remaining patient is 13 plus minus 10. And we expected to complete our recruitment by end of this year. Further statistical analysis will be conducted for univariate and multivariate regression analysis to identify risk of factors and predictor for delirium. And we also gonna do pre-specified subgroup analysis of primary outcome. We are interested to look at a specific population included in our trial, like HIPIC, transplant, heme oncology, and we did have 1 COVID patient that was recruited after the midpoint analysis and was randomized to ketamine. So in summary, ketamine has multiple utility in the ICU. Our trials will provide further insight for the role of this agent as an ergosedative agent for mechanical ventilated ICU patients, as it includes mixed ICU cohort and focused on patient-centered outcome like duration of mechanical ventilation, and aims to describe also our experience of using ketamine in an era that emphasized live sedation. The midpoint, nonetheless, this midpoint analysis may underestimate the true assessment of primary and secondary outcome, or further explore an accurate assessment for safety and need to be interpreted with caution. This is what I have for today, and happy to take any question. And also I would like to take this opportunity to thank Saudi Critical Care Trial Group for providing the feedback for this study proposal and the initial footsteps for this trial. And happy to take any questions.
Thank you, Dr. Marwah, for this outstanding presentation. It's really great progress on this trial, very well designed and conducted. And this is a way to conduct clinical trials, to conduct a pilot study. So I'm very pleased with this progress, really fantastic. I have a few questions, and maybe I will open the floor for other colleagues to have questions. So the main idea of doing a pilot study, I think, is not really necessarily to look at the clinical outcomes. In fact, looking at the clinical outcomes may not be needed at this point, or should not be done, because I mean, very small sample size by design, because it's small, it will be imbalanced, and getting information would be very hard. But more important than this is better understanding of implementing the protocol, better understanding of the application of the intervention, better understanding of enrollment and how you can improve enrollment. So I have a few observations. One is and I don't know that you can advise us better, you're a clinical pharmacist, on excluding end-stage renal disease. You have a good number of patients with liver disease who were excluded. And if there is no biological reason to exclude them, this will improve your enrollment. That's number one. Number two, I was a little surprised that you introduced ketamine, but the other analgesics did not change, essentially, unless I misunderstood it. So fentanyl dose did not come down compared to control. And that tells me maybe, I don't know, was the dose of ketamine adequate? So I think these are the certain things. If you cannot, if ketamine was introduced and did not lead to change in other sedatives, then I think it's kind of defeat the purpose, I guess. So you need to give enough of it so you reduce other sedatives. I thought this is the whole idea, unless I I was not very clear on this. So I think the whole idea of the pilot is maybe getting less. Certainly an important point. So if you do run a big randomized control trial, you need to see whether this is feasible or not. It may not be very feasible. It may be the hard thing to do. And if it's hard, you don't need to claim it as an outcome. Otherwise, you kind of shoot yourself in the foot. That we have an outcome, but we could not measure it. And then you select a measurement that can be done in an easy way. Or you can alternatively work on it to make it happen. So maybe if you want to address these points, one is the eligibility criteria and whether you learned something from your exclusion criteria to revise in the main trial. Second is the intervention. How can you improve the intervention? Were there any issues with the intervention? Was it effective? And third is related to the outcome measurements.
Okay, thank you, Dr. Yassin, for those comments. Yes, I agree with you. The eligibility criteria for the end-stage renal disease definitely will affect the ketamine.
End-stage liver, or I think it's liver disease that were excluded, right? Or
correct.
Renal.
No, we excluded only the end-stage liver disease, and we defined we defined that as a Child's score of C. However, if they are Child's score of B and A, they are included. So the reason behind it is the ketamine metabolite is an active metabolite, and it tends to have a lower metabolism in patients with a Child-Pugh score, and tend to have a longer duration of action and possible side effects on those patients. So that's why we choose the end-stage liver disease as one of the exclusions. In terms of the
but fair enough, yeah, that's important. But is it worse than fentanyl? Because fentanyl has the same issue. In fact, all sedatives have the same problem. So
yes, correct. So yeah, I agree with you. It can be revised, and those patients can be included as well. it will provide actually more generalizability to a wide range of population that we see in ICU. Did that answer the question?
Yes, yes.
Mm-hmm. And the other point is regarding the intervention. So we used a little bit pretty low dose of ketamine, and the reason behind it is we want to provide a light sedation that was studied previously in the previous literatures, and it's shown to be an efficacious with limited side effects. So that's the reason we use a low dose ketamine. Probably it's insufficient, and that's why we didn't see a decrease in requirement of fentanyl. And probably this is a point to the potential for improvement when moving forward for the bigger trials.
Very good. Excellent. Questions from the audience?
I can see there is Dr. Ghiyath raised his hand.
Can I ask? Assalamu alaikum.
Salam, tfaddal.
Thanks very much for a fantastic presentation. I have 3 questions. I noted the time to entry for the trial is 10 and 14 days respectively after mechanical ventilation initiation. I think it's a bit too long because you get other things that that will impact the extubation or easy to or weanability basically, which is weakness. I wonder if you can work on recruiting these patients earlier. This is the first question. Second question, I just want to allude on the outcome measures that you are looking at. Quite a few, and some of them will need vast number of patients. So I just heard this is a pilot. I see the outcome measures might need hundreds of patients. Thirdly, is the vasopressor issue. Even with the small dose that you reported, and as Dr. Yassin pointed out, there was no change in other sedatives, which is interesting. But we see a lot of vasopressor changes in these patients. This becomes a safety issue, and I would want, as an intensivist, to know more about this issue. Did that impact other things, fluid requirements, for example? Urine output issues and arrhythmias. If you're reporting the vasopressor increase, then I want to know more about it.
Thank you for the comment. Yes, for the time from ICU admission to randomization, it was noted to be like a median of 10 to 14 hours. And this is because of the barriers we have. We need to make sure there is no objection from the ICU physician, and until we approach the families and get the consent.
My mistake. I thought 14 days, so skip that question.
No, it's 14 hours. It's only 14 hours. So it really takes a lot of time to, or a lot of tasks in order to, prior to randomization, to make sure there is no objection from also other services like a surgery or neuro, if the patient under those services. Regarding the vasopressor requirement, we are planning to do a multivariable regression, adjusted multivariable vasopressor requirement to see the effects of other therapies like fluids requirements and the hydrocortisone, and would that potentially impact the vasopressor requirements compared in the 2 arms. I don't know if that answered the questions or not.
Yeah, thanks.
Mm-hmm.
Maybe I'll follow up on the same point.
Can I say?
Dr. Marwah, if you put the consort diagram again, I'm back to the recruitment because I'm going to the basics. So you said you have to get approval of so many people, which it happens everywhere. So how many of the patients, because I don't see this here, how many patients were eligible and they treating teams refuse to enroll them? Should be reported. Should be in the consort diagram.
We did report, we did documented this data, but however, it's not presented here in the slides, but we recorded those patients who the primary physician or the ICU consultant refused the recruitment of that patient.
Yeah, because this is an important group. It's called eligible non-randomized. They are not excluded, actually. So your last group, which is declined consent, these are not exclusion criteria. We have a paper in the Blue Journal about this. So declined consent, somebody, it means that the patient is eligible. He's eligible, you approached him to the consent, but he declined. He did not meet an exclusion criteria. Similarly, an ineligible patient who meet the inclusion criteria and the doctors declined him, he's eligible, not randomized. And it's important to put these numbers in the consort diagram in addition to the exclusion criteria.
Okay, sounds good.
Questions? Dr. Mohammed Bawazir, raise hand.
I would like to thank Dr. Marwah for this excellent presentation. I just would like to mention this study. Dr. Marwah is the fuel for this project, and without her help and her efforts, it would not be successful. We have faced several barriers, as Dr. Marwah mentioned, including lack of funding. We're doing our screening ourselves. Dr. Marwah is on top of that, and applicability of the intervention itself. Some of the nurses, unfortunately, they're not familiar. We've done several teaching sessions how to utilize ketamine as an adjunct to sedation. This is probably one of the reasons why we did not find a decrease in the adjunct sedation like fentanyl propofol. Yeah, this is one thing. Regarding Dr. Ghayath's question about the other parameters or physiologic parameters, we did not see any meaning for other physiologic parameters like urine output and other stuff. The aim of giving ketamine as an adjunct, we were hoping that the use of propofol and fentanyl will be lower, and therefore will have a lower use of vasopressors. But other physiologic parameters, we would not see any relevant for it in this study. Thank you.
Other, Dr. Haifa. Dr. Haifa.
Assalamu alaikum wa rahmatullah. Thank you very much, Prof. Arabi, for arranging and maintaining this great activity. And thank you very much, Dr. Marwah, for great presentation. I have comments. Like, one thing, when you use ketamine in anesthesia, that we're worried about hallucination and nightmares. So some patients, they develop very bad nightmares. So are you planning to interview patient and ask them about this? Or are you like using enough doses of benzodiazepine to prevent this? This is one thing. The other things, like, I think it's not a bad idea to exclude patient with liver disease, because this might affect, like, we don't know if this is the level of consciousness or hepatic decompensation, hepatic encephalopathy contribute to the level of sedation rather than just ketamine and use of other sedative. Thank you very much.
Thank you, Dr. Haifa, for your comment regarding the side effects of ketamine or the delirium effects. So it's one of the safety outcomes we are looking for. We are reporting the incidence of delirium as a safety outcome, in addition to the number of patients who started on antipsychotics. And we measure also the CAM ICU 48-hour post-randomization. We reported that as a safety outcome. So far, we only have, for the 40 patients included, we have 2 cases that developed delirium. One of them has a positive CAM ICU 48-hour post-randomization. And regarding excluding the end-stage liver disease, well, I really agree with you, since what I noticed, those patients usually, when they admitted to the ICU, they have hepatic encephalopathy and altered mental status that preclude the use of sedation to start with. So it's not a bad idea also to exclude those patients.
Thank you very much, Dr. Marwah.
One other question. I agree with you about liver disease. I just raised the point because you need to look at approaches to improve enrollment. So that was the trigger for my question, but this is up to you completely. I noticed that you are using in your standard of care benzodiazepines. And I think if you run a big trial, you'll be critiqued about this, not propofol, because benzodiazepine in the most recent guidelines is not the first line. So if you make any difference, people will say because you used an inferior regimen of sedation. So what's the rationale for using benzo on almost all patients in both sides, not propofol?
It's not all patients. Let me just.
No, in your protocol, you said our protocol is based on benzodiazepine. In the protocol.
So, yeah, some treating physician, they might use midazolam, especially if the patient has a hemodynamic compromise or significant hypotension. So they, which is a low proportion of ICU intensivists, so they use midazolam instead, since midazolam is relatively less hypotensive compared to propofol.
Yeah, I'm referring to a previous slide.
Dr. Yassin, our hospital protocol is based on analgesia first sedation. So we start fentanyl, then propofol, then ketamine, midazolam. This is our hospital protocol. However, as Dr. Marwah mentioned, some physicians would prefer using midazolam as an alternative to propofol and fentanyl, or midazolam, fentanyl, rather than propofol, fentanyl.
Okay, good enough. That's not the message I got from a previous slide. Okay, very good. Any other questions? Dr. Ahmed Madi?
Assalamu alaikum. Thank you, Dr. Yassin and Dr. Bawazir, Dr. Marwah. A very good, actually, and comprehensive talk about the ketamine. I actually have a question about, I can see you did exclude the patient who is asthmatic patient from the study. Even he can be used as a bronchodilator. This is the first question. The second one, can I know how are you manipulating the dose of ketamine as well as the other sedatives or narcotics or in the intervention groups, how you are playing with the doses, the nurses or with the protocol, you are going higher with the ketamine dose to achieve your target RAS in intervention group, you are going higher with the other sedatives or analgesic drugs. Thank you.
So for the reason we excluded status asthmaticus, because the dose we're using here in our protocol is a nilgo sedation dose or sub-anesthetic dose, which is totally different than the dose being used in a status asthmaticus patient. However, we use the advantage of ketamine using as a bronchodilator and preserve respiratory drive, and that's why we choose the duration of mechanical ventilation as our primary outcome. Regarding the titration of the other sedative, we do have a protocol, like stated exactly what the nurses would do in terms of titration of the other sedatives. And this is the rate will be adjusted according to the target RAF goal left to the ICU physician. So as I mentioned, it will be like if the patient deemed to be excessively sedated, the other sedatives will be decreased first and ketamine will be continued until the patient reach the team desired RAS. But in a situation of patient having excessive sedation, ketamine can be discontinued. On the other hand, if the patient is deemed to be agitated, the other sedative rate was increased, or PRN bolus is added, or Presdex was added, and the decision to continue or discontinue ketamine was left to the ICU physician. So we do have like a stepwise approach what to do once ketamine starts or once the patient is randomized to ketamine in order to help the nurses titrate the other sedatives.
Okay, Dr. Marwah, really excellent presentation and great progress. Very, very well designed and conducted the trial. And I think this pilot study gives a lot of insights on how to implement the protocol. And I hope the information you gained from conducting this pilot study will help you forward in the conducting the main trial. So congratulations on this excellent work. This is the way to go. Thank you very much, Dr. Marwah and team, and Dr. Mohammed Bawazir and the whole team. Thank you very much.
Thank you, Dr.
Thank you. We have an update from Dr. Riyad Saeed. He will be giving us a brief update on his project.